Epic's team is remarkably customer centric. Take that as a compliment. I think it's a great thing. They are also really, really well trained not to take phone calls from people like me. I was actually really glad that I met Spencer at E.M.S because they are incredibly responsive to what their customers demand, not what other people say. I want to send data in Epic. We have a method. Fill out the form online, and we'll get back to you if we care. When is the last time you demanded of Image Trend that they play in that market space? Individually, you have. Yeah. But that's my point. Right. So this is exactly where what Kevin was talking about, I think, is right on. There is a general acceptance. Individually, you might be too, I think it sucks, but you might individually have too small a service to register. But a region does, right? When is the last time the region basically flexes the power that you have? The single greatest driver of innovation is competition, right? If you believe that you are so comfortable, you've got a contract, it ain't going anywhere, you're actually getting dug in deeper, et cetera, language that certain other company, for example, has used, if you want to make this happen, this is the way you have to go. That type of language is anathema to innovation, right? Especially if the person who's receiving it doesn't necessarily know how to push back. But unless and until those Image Trend users say, well, we have an option for sharing data with our hospitals from our E.M.S system, are we using it? If we're not using it, why aren't we using it? Can it kick out the CCDs, for example? Like, are there technical nuances that there, right? If it works, use it. You are not going to hear me say you have to use my system. In fact, I kind of relish the idea that if an industry ends up with one portal for ESO, one portal for Image Trend, and us for everybody else, it's really just a matter of like 3 tabs in a window. It's not a huge, as you say, it's a portal. It's not a huge lift. If the juice is worth the squeeze and the cost savings and the justifying the idea that you switch to the next portal. Al and I were talking about that during the break. The easiest way to make that an easy process, use the same password on all 3 windows. BFD, right? So you can figure that out. It's not a huge lift, and as long as you're getting value, that's fine. But the question is, do all the participants feel that they are vulnerable enough that if they stonewall you and they say, hey, I got busier things going on next door, I can't get to you, or the ticket's been sitting in support for 9 months and I'll get to you when I get to you, do they feel like you're going to undertake the effort of saying bye? And in general, that is not the case in this business. And a lot of that, again, this is where, with kudos to the EHR side of the world, there was a time when that was the case. And now data sharing is mandatory. And in fact, it's actually getting stricter. There are new guidelines that are just closed their comment period that actually require interoperability capabilities. I commented on them on behalf of the E.M.S industry. I'll be happy to share that with you. If there are, the rest of the healthcare system has gone beyond proprietary data ownership, and E.M.S still has not. I'm working with a service in Massachusetts right now that switched off of one of these systems that's on this page right now. And it has been roughly 6 months, maybe more, and they still can't get their past data sent to them. The E.M.S agent, the old EPCR company refuses to give it to them. One system another one that we brought over, they were given spreadsheets as the output of their charts. The problem is you just acknowledged a challenge that you had, and yet that practice persists. And there's not a single company that I can think of, a single agency that I can think of that has ever dragged its vendor through the dirt, for example, or into court or wherever, or publicly called them out for saying, we needed our data from you and you held it hostage. Maybe locally, right? But we all know this is a small industry. There's not a whole lot of people go out on record saying this guy screwed me over. And so the things are allowed to persist and they continue to go, right? And if you look at the listservs, the NEMSMA listserv, for example, it's rife with everybody. There's a couple of people who are champions of certain companies that they work with, and that's fine. But there's this sense of inevitability. And therefore, nobody ever got fired for hiring IBM was the old phrase. Probably Epic benefits from some similar. Epic is the big boy in the room. They often are. You're at least going to consider what they have to offer your service if you're looking at electronic health records. There's nothing wrong with that. But are you looking at other smaller options, local options, figuring out whether it fits? And unless and until that happens, there is a disincentive for the ones who are sitting atop the castle to move away from it. That power is in your hands, not in mine. Right? I can offer innovations that you may or may not care about, but I can't be the one to hold the people's feet to the fire who are already there. Individually, it's very hard for you to do as well. But as a group, you have enormous power. I mean, I've often found myself saying, it's not just with respect to technology, of course. The only industry I've ever found generate more goodwill when it dresses up in its dress uniform is the military than fire and EMS. You want to see power, put on your dress outfit and walk down the street. You'll get everything you ever want from anybody. It's the most compelling show of force. And yet, internally to our industry, we fight about everything, right? How many national associations of whatever do we have fighting with each other? It's this total internal fracture that makes absolutely zero sense to anyone who's not on the ground. I still don't get it. I've been here a decade, right? But this is one example where everybody knows the problems and everybody has common needs. That's why I mentioned early on that I have an interest in sort of creating this, not an association, but more like a think tank, right? Where the common challenges that we face, like how to affect interoperability and how to package data sharing so that you could go from MetaView to AmbiPro, from Stryker to ESO, and have it not result in complaints. That doesn't benefit anybody, right? Portability of information is power. And it's not just with respect to HIPAA, right? The idea that you can take if you don't like your doctor, you can find another one, that's power in your hands as a patient. You have the same power as a provider to be able to say, if you're not giving me what I need, I'll find someone who will. And I've seen agencies get so desperate, seriously, that they considered using Salesforce as their documentation system. I mean, I have seen very few EMS agency leaders who know how to factor total cost of ownership. I actually have a nifty little spreadsheet on my website if you wanted to check it out, where we compared the cost of a free system that was pre-configured by a state versus a paid system that is individually configured by agency, and the paid system wins every time, except in volunteer agencies that don't have any cost. Because it turns out that if you have a custom system that takes you 15 minutes to document, for example, it costs you whatever it costs, right? But if you're a paid service and you have a free system and it takes you, say, 30 to 45 minutes to do your documentation, think about this. We talk about per chart cost from a budgeting perspective. If you have a free system, you make $15 an hour, and it takes you 30 minutes to write a chart. Every chart costs you $7.50. Nobody thinks about that. It never comes up, right? It comes up as what's the software cost, not what's the total cost, which involves the effort. But if you have a system that is customized to you, maybe it has an upfront cost, but you amortize time, and all of a sudden those costs plunge because they're exactly what you need. Maybe you have to eat some money out the door, but you're going to make it back in spades. And the entire state of Kansas does not know how to do that. That's actually where I came up with this model. As I was sitting in the Kansas EMS Association meeting, and the state's trainer told me it takes him 30 to 45 minutes per chart to do their documentation. I said, well, why do you use it? And he said, because it's free. Swear to you, I had that conversation. He said, it's free. I said, are you paid? Yeah. It's not free. Do the math. It's literally 3 lines on a spreadsheet. Time, cost, total. He had never done it. And it is the most remarkable thing. So the demand coming from you all to say, if we're going to make our processes efficient and we're going to share the information and so on, and we're going to build these programs out, we need to look at total cost. And I think your point was very well taken. That's a business conversation, right? That involves understanding how you're going to sell it, not just as what we're going to. I mean, you were talking about that before, right? If you're gonna sell the idea that you have a program, you need to be able to look holistically at what it's costing you, what it's getting you, and that looks at a whole lot more than how much am I shelling out for a piece of software or for a truck or for a hose, right, or a cannula. What am I getting? If you're looking at community paramedicine, like here, this is why when I'm focusing on these sort of managed care programs. If you look at the managed care programs, that is an election of whether or not to engage in it, right? There, these do apply, right? Municipal numbers are quite different, right? So when you start looking, again, if you're a function of local government, for example, you don't need to turn a profit at all, right? But if, for example, a Gold Cross ambulance, private ambulance, right? So these numbers very much can matter in terms of where do we find efficiencies, what programs do we engage in. Do we or do we not participate in a regional effort, for example, and being able to present to leadership a bottom line calculation? You can't do a bottom line calculation without looking at all of the operational expenses associated with that. Municipal services have generally, in many cases, not had to do that. Right? You don't shut down the fire department. I mean, you can. It's not really going to bode well for you. That came up in our neck of the woods in California. So, we have strange tax processes in California. And the first time that I pissed off my county was when I published a response to something called Measure Q. Measure Q was a $75 per parcel tax to keep 10 of 28 fire stations open in our county. 40% of our fire stations were on the block in a tinderbox county during a drought. It turns out the problem that the voters had was with the pension process, and that's a conversation perhaps worth having, but not in the context of, do I keep my stations open during a drought? That seemed like a pretty stupid context to have that conversation. And it got voted down. You had the opportunity to vote on this. You should have voted properly on it and separated the conversation around long-term pension liability versus, do we keep the fire stations open? So every so often that comes up. But it tends to get intermixed with these other conversations, as opposed to, are we making the right decisions around process, technology, people, vehicles, et cetera, et cetera. So I think you make a very good point in that the business discussion doesn't necessarily map onto municipal mandatory services, I guess, for lack of a better phrase. But to the degree that you're looking at utilizing data to explore other programs that are beyond that initial charter, then it absolutely becomes a question of, is this a good idea? If it is a good idea, how are we going to do it? If it turns out the numbers don't work, maybe we don't do it. And so this is why I just wanted to highlight as an example of this cost analysis that typically doesn't get done. And you talk about things like the 30-day readmission process and system saving costs. What if it turns out the way that you pitch this to your community is you're going to save the system money and avoid readmissions? Avoiding readmissions you might do. Again, this came up yesterday as well. Doesn't avoiding readmissions mean you're making the patients healthier? I said, no, those are not. Maybe the person needed to go to the doctor and you kept them out. So that's one possibility. The other part, and the part where they typically crunch on themselves and become like crashes on the rocks, is in the promise to get your costs down. Because if you are a patient who is a heavy drinker, as in this example, or a heavy smoker in this one, you probably haven't gone to the doctor a lot, right? So otherwise, the doctor's going to tell you to stop smoking, stop drinking, and yada, yada, yada. And so all of a sudden, you've got a patient like a friend of mine. He walks outside, takes a CPAP out, puts a cigarette in, finishes the cigarette, puts CPAP on. And this is a guy who is a very, very smart fellow. But the fact is he doesn't go to a doctor because he doesn't want to be nagged and he doesn't want to be told, right? And so you put him in a CP program, and all of a sudden, you're making sure he gets to the doctor. You're making sure that he's picked up because he doesn't miss his doctor's visit. He's taking his meds. You're checking on him. His costs don't go down. They go up a lot. And it turns out that the same thing with drinkers, right? If untreated psoriasis of the liver is not expensive, treated psoriasis of the liver is expensive, right? So drinking at home is cheaper, but it's not healthy. The problem is we don't have good metrics for healthy, right? So we need to get to those, and I think that's where you hit it on the head. That we need to start defining what that is. With the smoking one, I think is really interesting because the research lays out, and again, citations are down here, so I'm happy to share this with you. The idea that after 365 days, your costs essentially revert to the mean is a really, really interesting finding that is absent in almost every publication except mine around community paramedicine. And so you have these programs that have promised to reduce costs that have done exactly the opposite, and they're getting no credit. In fact, they're getting shut down because they can't prove their value over 30 days. In fact, they made it worse. They made the patient more expensive, but they made them healthier. And that's why insurance companies are starting to get wise to the idea that if we fund these programs holistically, as opposed to a knee-jerk keep you out of the hospital, process, then all of a sudden you are able to demonstrate a reduction in their risk and long-term cost, as opposed to just keeping them out of the hospital. There was a program in Arizona. I was recently talking to the chief. It was one of the first community paramedicine programs that actually got shut down. It was remarkable when he explained to me why they got shut down. Well, yes, they did too good a job. I wish Al was here to talk about this, because you guys can probably hear from the hospital side too. Like when you talk about the readmission provision, It's a penalty, right? It's not negative. It's a penalty. You make less money. Doesn't mean you are paying back money, right? So in this case, the hospital actually ended up losing money because the CP program was so active. They had patients not coming in, and the CFO's line was basically, stop your program, thanks. Get patients healthier, but the charter wasn't written properly. So, and in fact, that was one of the programs that the funders behind it essentially have said they did not build that into the program. Not for nothing, but to put a fairly square, spotlight on LifeQuest and whatnot, is I tend to think that, again, collecting and measuring and then collecting on the value that are provided in these programs is something that billing agencies have a huge opportunity to do that they have not done. I don't know of a single billing company across the country for E.M.S that engages in community primary medicine. It's not mileage based, so they basically say, well, we don't have any way to build it, so let's build it. You'd end up being the only one. It would be amazing, because measuring this stuff is not easy, but monetizing it is phenomenal. Right? If I can show that over 365 days, I've taken this person and reduced the risk associated with it, and the cost reverted to the mean, and they're healthier, that's a program that you can sell, right? The only two programs that I mentioned are truly definitive in the value that they immediately provide. Food, access to food, and access to friends, basically. And this one I think is really sad, but incredibly potent in terms of being able to highlight the role that you guys can play, and it doesn't necessarily need to be expensive. It doesn't necessarily even need to be in the field. There's a company called Great Call that was acquired by Best Buy a couple years ago, and it was essentially phones that were designed for seniors. It has like 3 buttons on it. One's an emergency, and then there's like 2 emergency calls, right? Or 2 other points of contact. Imagine how powerful it would be if one of those phone numbers was to a non-emergent line somewhere at the firehouse or E.M.S station, and every couple hours even call, hey, how you doing? Just checking in on you, right? Just see the ball game, etc. I'm going up to Green Bay next week. Hey, how them Packers? The idea that you can have that conversation, and when you look at the actual impact, research out of the London School of Economics finding that $1 spent in preventing loneliness generates $3 in the actual monetary system saving. You don't even do anything. Just be a nice person, right? Ask this person about their grandkids that they haven't seen. And if whether you need to document that or not, sure, fine. You can document that you made a phone call. But imagine the impact you're going to be able to actually measure that you have improved yourself, not just in terms of avoiding readmissions, but in terms of making these people healthier in terms of whatever it is that we measure, right? Are they calling for help? Are they on a scale of 1 to 10? How sad are you? Interesting data point. We don't capture that. We do capture the pain faces, right? Scale of 1 to 10. How about a happiness index? Doesn't exist. Imagine if we put that into E.M.S. And on that last happy note, I will end.